What we see here is an ultrasound scan using a curvilinear probe, displaying a tubular, blind-ending structure approximately 9 millimeters in diameter, surrounded by high echogenicity fat, positioned about 2 centimeters below the skin surface. This is an important first finding, suggesting the location of the appendix. Of course, with ultrasound, being aware of the exact region being imaged is crucial for accurate diagnosis. Now, the presence of high echogenicity fat surrounding this tubular structure suggests inflammation, which leads me to think we're dealing with an inflamed appendix. But before jumping to conclusions, it's necessary to assess further and correlate with clinical findings. Has the patient presented with typical right lower quadrant pain, nausea, or fever? These symptoms would help confirm the possibility of appendicitis. When I examine the cross-sectional view of the appendix, it's important to note that the appendix exceeds the normal diameter of 6 millimeters, which is a key positive finding. This makes appendicitis the most likely diagnosis. However, to further strengthen this suspicion, the use of a high-frequency linear probe would be appropriate to obtain even more detailed imaging of the appendix walls and surrounding fat. Hypervascularity, if present, can be confirmed with Doppler ultrasound, which further indicates inflammation. At this point, it's worth mentioning negative findings. For instance, there's no evidence of a periappendiceal collection that would suggest an abscess, nor are there signs of free fluid, which could imply perforation. Both of these would be concerning complications of appendicitis, but thankfully they don't appear to be present here. Another differential to keep in mind is a mesenteric adenitis, which can mimic appendicitis clinically and sometimes radiologically. Mesenteric adenitis, however, typically shows enlarged mesenteric lymph nodes without an abnormal appendix, something we do not see here. Now, thinking about what the examiners may ask during the viva, they might want to know about the typical ultrasound criteria for diagnosing appendicitis, namely an appendix greater than 6 millimeters in diameter, non-compressibility, and hypervascularity on Doppler imaging. They might also probe about the imaging modality preferences for different patient demographics, for example, preferring ultrasound over CT for children and pregnant women to avoid radiation exposure. In terms of management, this ultrasound finding would lead to a prompt surgical referral, particularly for patients with compatible clinical findings of acute appendicitis. While CT may be considered to rule out complications, such as perforation in cases where ultrasound is inconclusive, here the ultrasound findings seem fairly conclusive, so surgery would be the next appropriate step. So this is a classic case of appendicitis on ultrasound, a common but important diagnosis to make accurately. Thank you for staying with me on this case. If you found this discussion helpful, make sure to subscribe to Radiology Made Easy for more insights into diagnostic imaging. Catch you in the next one.